Hi everyone, next thing we're going to go through is our straight leg raise and a few variations on the straight leg raise. So Glenn's going to take BJ through that straight leg raise technique, and we're just going to kind of discuss and go through that as we do.
Great, so basic straight leg raise, make sure there's no flexion at the knee. So my hand comes across here, other hand gripping under the foot, and my forearms bringing on the dorsiflexion component. Yeah. So from here I can hold all of those points on here and just bring PJ's leg up nice and easy, watching his face and getting feedback from him all the time. Let me know when you feel a stretch. Yeah. So from here, there's a couple of things we can do. We can either sensitize it with the head. So if you bring your head up for me, does that increase the stretch or not? Obviously, if it changes it and relax down, if it changes it full stop, I would interpret that as a positive sign. What you'd expect if there was a neural involvement was that that would increase the stretch or increase the symptoms. Or we can sensitize it from the ankle. So I just change my hand hold. My forearm now is locking and keeping that extension at the knee, and then I release off at the ankle, yeah, without losing any of my hip flexion. Does that change it? Yeah. And then we can see if there's any more movement as well.
And again, I think it's important to remember that a lot of people are going to be tight potentially in their hamstrings or in their posterior structures. So it's important to relate it to their symptoms, not just is it painful, but does that reproduce your symptoms? I think that's a really important question, and how you phrase that question is important, because if they're just feeling a stretching pain down the back of the leg, which a lot of people will, they might say yes, but they might not actually be reproducing a neural symptom or their particular symptoms. So I think that's really important as well.
Yeah, and I think it's important to stress that a stretching sensation in your hamstring and your calf is a normal response to what we're doing, because we're putting them on a stretch. Obviously, other side, vital. Yeah, so if there's a massive discrepancy between the two sides, that's obviously going to be your major factor that you're looking at, because people's hamstring length varies hugely, so their normal straight leg raise test will vary hugely as well.
I think, isn't it, so below 30 degrees, if someone's got below 30 degrees of a straight leg raise, it's quite indicative of some discogenic type pain as well.
Yeah, I think that this pathology will definitely, well, 9 times out of 10, not always. I've had a few cases where it's not been the case, but most of the time, if you've got a significant disc involvement, the straight leg raise will be very reduced. Anything over 40 degrees is classified as normal. You know, I mean, we interpretate it as you will with each client, but we have this idea in our head that we should all get up to 90 degrees. I certainly couldn't do that. And if you read in Butler's work and things like that, normal response to this is a big variance between 40 to 100. So it's quite a big range actually. 40 is not that much.
And also, if you look at the cross leg straight leg raise, so essentially exactly the same straight leg raise, but on the other side. So if you've got pathology or right-sided pain, and you do a straight leg raise on the left-hand side, which is positive, that's quite indicative as well, quite a big sign that there may be some disc pathology going on.
I mean, I've had clients in the past where just doing that aggravates them without any lift at all. So just bringing the ankle into dorsiflexion, and you're totally right. If that was the case, I wouldn't try and force that to get a measurement. I would test the other side, and usually there's a reduction on the other side. Like you say, you'd be thinking disc pathology or inflammation around the nerve.
Okay, great. So if we want to bias that towards to kind of different nerves in there, how would we go about doing that, and which nerves are we testing when we're doing that?
Okay, so let's take a look at peroneal bias. Yeah, so very common. See this quite often in chronic ankle strains and stuff like that. The peroneal nerve runs along the outside and across the front of the lateral malleolus. So we want to try and bias that structure. So I like to come under here, and now I'm literally going to block PJ's foot into plantar flexion and inversion. Yeah, so I'm holding that position. Again, we want to maintain that extension at the knee, so my hand will rest on that joint to keep that in place. And then I'm slowly going to lift up here. Again, very slowly. Watching PJ's reaction. We're getting a little stretch there. I feel a little bit of resistance there, we're getting a stretch. Again, we're looking symptom reproduction, pain. It's quite normal to feel a stretch along the lateral aspect of the shin here, because that's what we're tightening up essentially, and then I can just release that off. Yeah, does that change it or not? Bring it back on. Again, you can do the same thing with the head if you wanted to get a little bit more information that way.
Okay, cool.
as with the neural testing that we went through earlier, standardised setting every time. Yeah, so if you use one pillow in the first session, you want one pillow in the second.
Yeah.
If his arms are by his side, which they should be by his side, make sure that's the case next time you try it. And sometimes your clients will come in and hands behind the head and all that kind of stuff, so you want to ensure that. Yeah.
Yeah. Okay, so then what about our tibial nerve?
Okay, so tibial nerve, this is more associated with sort of medial ankle pain. So you would want to bias that, yeah? So we want, for this one, we want dorsiflexion. My hand would come around the calcaneus and I'm pulling him into eversion. So I've got that nice and locked before I lift. Yeah, so I've got my plantiflexion and my eversion locked in there. Again, hand on the knee, ensuring that I keep knee extension. And then from there, I'm just going to lift. Same thing again. Difference here, we've got a nice handhold here, where when we bring on, I'm feeling a little bit of resistance there, we can unlock the eversion component. Yeah, so you're being quite specific. You don't want to just unlock it all to begin with. We want to just unlock that eversion component. Again, does it reproduce your symptoms? Does that ease it off? Does that change it? Same thing with the head. Are we getting medial ankle pain reproduction or something like that?
Mm-hmm.
Yeah.
Okay, and then lastly, sural nerve.
Sural nerve, a little bit more difficult with the handhold. You want sural nerve, you'll be getting lateral ankle pain again. The sural nerve sits posterior to the lateral malleolus though, so you may find your symptoms more around that area. Yeah, so for here, you want dorsiflexion, and this time you want to come through and bring him into inversion. So I'm blocking here, plantiflexion, and then I'm pulling the calcaneus into inversion. So now my forearm has to ensure that the knee stays extended, so I'm making a kind of lever. Yeah, and I bring it across here, just going to shimmy back. I'm feeling a bit of resistance there, yeah. So now I can release off that inversion component. How does that feel? Does that change the symptoms? Yeah, same thing again. From here we can we go a little bit further after we've done that? Yeah, I felt the resistance go down.
Perfect. And I think with all these neural tests as well, again, there is no absolute way to do it, in the sense that, you know, everyone's neural system is going to be slightly different, and the way the nerves could be irritated is always going to be slightly different. You can't just say it's not a two-dimensional structure, and therefore you're never going to get a perfect, just by doing this you're always going to get that nerve, or just by doing this, you know, you can't always say it like that. But it gives you a good idea. So the other thing I think you can sometimes do as well is add in a bit of hip adduction or hip abduction.
Yeah,
that's another thing that you can do often with your, for example, with your peroneal or your lateral structures. Going into that adduction is going to increase that stretch as well.
Yeah.
And again, if you were thinking maybe more, or some of the nerves, when we do the pro-knee bend later in a later video, you could come into more abduction, which would again then stretch a little bit more down the inside of the leg. So yeah, it just, you can, you know, as long as you write down and document what you're doing in terms of exactly what has brought the pain on, what's irritated it, and what position you're in, I think that's the key thing. But adding in different hip components, adding in, and then again, you might then be able to say, well, maybe the neural tension is developing somewhere around the hip, so you could then look at that.
Exactly.
Or it could be developing more around the ankle, depending on those tests.
And I think we teach this in a standardised way, because I think it's easy to learn that way. But as Chris was saying, the nervous system is not a one-dimensional system, so it's very fluid. And the point at which you wind up the neural system to begin with is the point that's going to be highlighted the most.
Yeah.
So we show it in this way, where we're continually bringing it on first at the ankle. But if you had very irritable symptoms around the ankle, you might choose to start at the hip first and bring that on incrementally, because they might be too irritable to just bring them into that position, or especially that peroneal one.
Yeah.
Yeah. So we show it in a set way, but you can modify it with however your patient is presenting. Likewise, if they've got very low irritability and you want to really wind them up, then you would start definitely around here and put all that on first. Yeah. So it's however your client is presenting would dictate what order that I put these in.
Yeah, like you said, I think it's, you know, practice the standard tests, get really comfortable with those, and then you'll be more comfortable when you've seen more patients, in terms of knowing when you can add different things on at what times, but initially just get used to doing the tests as they are, the standard tests, knowing what nerves you're stretching, getting used to that, and then you can start to modify things and start to improve things like
handling's key, and you get your handling better by just practicing these standard ways, and documentation is key as well, because if you do start going off on a tangent and thinking I'm going to put this on at the end, you just have to make sure that's documented in the notes, and you do it in the same way the next time. Because if you put that on last now, and then I get PJ back in a week and I put it on first, and then his test's gone down, he hasn't necessarily got worse, it's just the order that I've performed each sensitising movement in.
Yeah, perfect. So that is our straight leg raise assessment.